They want to do a prioritize.
All right. Until technology decides to catch up with me, we are recording. And we're going to pull open the modules so we can look at the modules and talk about these medications that you guys have been looking over and looking at your PowerPoints and studying. Ms. Guyton? Ms. Guyton? Yeah. Technology. So as we go through perfusion, Ms. Curley, I've got the module pulled up to share. Ms. Curley has gone over your anticoagulants, which you studied. I know we all have been in clinical. How many weeks have we been in clinical together? A lot. 6 weeks. How many more weeks do we have left? 2 at least. 2 or 3. 2 or 3. Okay. So we're all given medications at this point, right? Yeah. So these, all of the medicines that you give are very, very important. And I say that in particular to this group of medicines that we're going to talk about today, antihypertensives. So what is hypertension that you've learned thus far?
High blood pressure.
High blood pressure. So we would give an antihypertensive to do what? Lower the blood pressure. There are lots of different antihypertensive medicines. Let me talk about this. You've watched the video on iron. What does iron treat?
Anemia.
Anemia. And also low iron levels, right? When we're in clinical together, if you're instructor, I may say to myself, if I ask you, you're giving iron, I may say, do you know what the iron level is? And your response would be, yes, Ms. McCart, iron level is whatever the iron level is, right? Some of these medications in the antihypertensive world, ACEs and NURs, heard that name before? Those medications have an electrolyte that we need to be knowledgeable about. You know what that electrolyte is? Potassium. So all these electrolytes that we'll talk about with antihypertensives, I'm not sure why it's doing what it's doing. You need to know that. So if you're given an ACE or an NUR, the potassium level is very important. Just this last week, for instance, we had a patient whose potassium level was 5, and she was due 40 milliequivalents of potassium. And we made that an ISPAR situation. What are we going to do? Call the provider. Hey, this is the card. I'm taking care of your patient in room 100. And this patient's potassium is 5. She's ordered 40 milliequivalents of potassium. Do you want her to have it? And the answer was no. So we discontinued it. So if you guys have the model pulled up, that's what we're looking at. It's giving me some scenarios of where we need to be. So alpha and beta blockers. What's alpha? Where are alpha cells in the body? In the vasculature, in the vessels, what do alpha cells do? They squeeze and dilate those vessels, right? Yes. Where are beta blockers?
Heart.
Beta 2. So I have 1 heart and 2 lungs. Beta 1, beta 2. And then I have calcium channel blockers. What does calcium do to the heart? Makes that squeeze hard, right? Calcium influxes into the cell, causing the sodium and potassium to help squeeze that muscle. Make sense? All right. So we're also going to talk about medication that normally is given for heart failure. Have you talked about heart failure in class yet? We're going to talk about it just a little bit today when we talk about digoxin, another name called lanoxin. You'll see that medication. And you'll be
Sorry,
Thank you.
it was just an easy button push.
So you'll see that medication given. How many of you are on one more? How many of you are on two more? Cardiac patients on two more. You'll see this medication white. So what medications is Ms. Curley going over with you? Anticoagulants. Okay. Antiplatelets. And then the last class that we're going to talk about is the antilipidemics. Big word, right? What's lipids? Fats in the blood. So we're going to talk about medications that lower those antilipidemics. All right. So if you will pull up your cardiac medication, it says cardiovascular meds. Have that one? Good. Do you guys see how I've tagged in my book? On my tags, I have all the medications that we're fixing to go over. So if you have a book like this, I encourage you to do that. If you don't, then write your pages down on your notes for your slides. So we said, as we talk about some of these cardiovascular medications, we're going to give antihypertensives, right? So we're going to be decreasing blood pressure. So if I'm given a nitrate, what does the word angina mean? Right? These are words on this board that you'll need to remember. What's the other half of that word? What is pectoris? Chest. Chest pain. When I give an antianginal, I'm trying to help this patient that I'm taking care of decrease their chest pain. When I do this, I'm going to decrease their blood pressure so the heart doesn't have to work so hard. Make sense? Okay. You'll hear me say several times today, does that make sense? Nod. If you don't make sense, speak up so we can talk about it. So across the bottom of the screen, you don't need to know what that is. That's just a rhythm strip of the heart's electrical activity. So what is this used for? To treat chest pain. Your client has chest pain, what do you need to do? We're going to give a nitrate, but what do we have to do first? Check the blood pressure. What do we do with pain? We ask about pain, right? We assess. So as we assess the pain, can you tell me where your pain is? It's in my chest. Can you tell me the number on a scale of 0 to 10? And can you tell me what kind of pain are you having? Is it heavy, tight, squeezing? Assess those things. That is a nursing consideration to do, right? Okay. So we're going to treat the chest pain. And how does it work? It dilates the coronary arteries, but nitroglycerin also dilates veins and arteries everywhere in your body. You get that? Dilates your coronary arteries, and it also dilates your arteries and your veins all over your body. So I really need to be mindful of this client's blood pressure, right? Okay. Why am I doing this? Why is my patient getting a nitrate? Help their chest pain, dilate their coronary arteries so that I can get more blood flow to that heart so they can have more oxygen. Hopefully the pain will go away, but that's not always the case. So we're fixing to give a nitrate. What's the nitrate called? Nitroglycerin. It also decreases the workload of the heart and decreases oxygen demand, supplying it more oxygen. Does that make sense? I'm dilating open my vessels so I can get the blood to my heart and it helps it work better. Remember I said it also dilates the peripheral vessels, also dilates all the arteries all over the body, and decreases venous return. So nitrates can be given, everybody say with me softly, so we're not loud, nitroglycerin. Nitroglycerin. So the abbreviation for that is NPG. It can be given sublingual, tablets under the tongue. It can be given as a spray, a topical cream to the skin, IV, or a transdermal patch. All these ways nitroglycerin can be given. Okay. What does nursing need to know?
Blood pressure.
Blood pressure. Very, very important. Side effects here says I can cause, if I give nitroglycerin, I can cause hypotension, right? Okay. I can also cause this client to have a headache. Why is that? I'm dilating all these vessels, okay? Dizziness, because my blood pressure dropped. If I give it sublingual, there's a special way to give nitroglycerin sublingual. I give a tablet under the tongue as before I take their blood pressure, so I know what it is, give the tablet, and I wait 5 minutes. If the pain doesn't go away, and I take the blood pressure, and the blood pressure is 100 over 50, I have to do the second one. But what do I need to watch as I give the third one? The blood pressure. The blood pressure. American Heart Association says if you open that bottle, 14 gram bottle, and you give a nitroglycerin sublingual, go ahead and call 911 if you are not in the facility. Reason being is if they're having chest pain, they need to get to the facility so we can check out this chest pain. Okay. If you're in the facility, things change a little bit. I can go ahead and give my nitroglycerin as I'm checking my blood pressure. But I'm also, if I'm on the floor, I'm going to call a rapid response because I need help, right? Yes, I do. But you will see morphine ordered and given for chest pain. But if you're at home, sublingual every 5 minutes times 3 doses, and they need to sit down or lay down as they take this. And my question to you is, why do I need to sit down or lay down? They get dizzy. can get dizzy, fall, or my blood pressure could drop so low, I can just pass out. Okay, make sense? Fresh supply should be given to a patient. They should check with their pharmacy at least every 3 months. When these folks take the nitroglycerin sublingual, they're going to tell you that there's a little tingle to that when they put it under their tongue. All right. Nursing considerations with nitroglycerin. If you are a male patient and you come to the emergency room complaining of chest pain, one of the questions that you are going to be asked is, are you taking medication for erectile dysfunction? Do you guys know what those medications are? Viagra is one of them. Because of the vasodilation from Viagra, the same thing happens with nitroglycerin. If I give the two together, I can drastically drop their blood pressure, as we say, in the toilet, in a bad way. So you have to be mindful when you have a male client to make sure, are they taking erectile dysfunction medications? Because you cannot give it nitroglycerin within 24 hours safely. Sometimes you will see it done, but there are parameters that will be followed. Do not take during pregnancy or while breastfeeding. And teach the client to sit down or lay down when they take this medication. Question. The client was administered the first dose of nitroglycerin at 13:05. For acute angina, what will the nurse evaluate prior to the second dose of nitroglycerin? Blood pressure. If the blood pressure is greater than 90, I can give a second dose. Keywords. If the blood pressure is greater systolic than 90, I can give a second dose. Okay. Good job. Questions. Ask me questions about nitroglycerin. You have it. Yes, ma'am.
Before you give that second dose, would you want to assess the pain level again as well? Or-
Absolutely.
So if there's like not any pain, would you stop? Would you still not give it?
If we're giving nitroglycerin for this reason,
Right.
then I would assess their pain level. If they have no pain, then 911 is on the way and they're on the way to the facility. Okay? Good question. Anybody else? Okay. Now, in your book, 6.8 in chapter 6 is all about nitroglycerin. When is nitroglycerin contraindicated? When the systolic blood pressure is less than 90. Somebody else said something. With eating medications. What else? Pregnancy and breastfeeding, right? So those should be all on that little piece of paper, your homework. Did we cover it all? Okay. So the next two words that you need to know are, on my pen. Y'all see my listing here? Chronotropic and inotropic. I'll tell you what these mean. We're going to give another medication called digoxin. You also hear it called lanoxin. We said earlier that that medication was for heart failure patients, right? What does heart failure mean? That my heart's not working like it needs to work. What does the heart do? It pumps that good oxygenated blood out to the rest of the body and also to itself, correct? Yes, right. Anatomy and physiology. So I have a weak heart. And I need to help this heart beat stronger and more efficient. So we talk about inotropic, the bottom word. Inotropic is we need to help the force of contraction to take the workload off of the heart. And this medication is going to help do that. Okay? If I'm positive, I'm helping squeeze, right? If I'm negative, I'm causing it not to squeeze so hard. Make sense? Okay. So there's the answer to that one. Negative inotropic says we're going to decrease the force of that contraction. We are under the cardiac med PowerPoint. Positive chronotropic. What does chronotropic mean? Anybody look that word up yet? Medications that adjust the heart rate. If I have a sick heart, do I want the heart rate really, really fast? It has to work harder. If I have a sick heart, do I want to slow that heart rate down and increase the contraction? That's what digoxin's going to do. What's the other name of digoxin? Lanoxin. So these are the two things that lanoxin and digoxin is going to do for this patient. I'm going to make a positive chronotropic effect. No, I'm not. I'm going to make a negative chronotropic effect by decreasing the heart rate. Inotropic chronotropic. Hold on.
What did you say inotropic means?
Hold on. We're positive inotropic and negative chronotropic. So we're going to increase the force and decrease the heart rate. Is that what you have? So there's that clarification. Okay. How's this work? Right there. Increasing the force and decreasing the heart rate. So I want to make that sick heart not have to work so hard. Okay. Heart failure, dysrhythmias means the heart rate's not beating like it's supposed to, or hypertension. It can be given as an antihypertensive. If it's given as an antihypertensive or any of the other reasons, what does nursing need to do before I give this?
Check the blood pressure.
Check the blood pressure and
Heart rate.
the heart rate. Just the heart rate or an apical heart rate? How long do I listen to an apical heart rate? 1 full minute. Where's the best place to hear? Right here on the chest. Okay. I'm sure that you all have listened to apical heart rates in clinical. So when we give digoxin, there's some things that we need to consider. It usually requires a loading dose. They need to get it in their system, get it working, and then they need to continue to take a smaller dose. Okay? There's a narrow window of therapeutic for this medication. 0.8 to 2 NG per milliliter. What does NG stand for? Nanograms per milliliter. So that is my dig level in my serum of blood that I need to check before I give this medicine. Make sense? Okay. If it's within this window, can I give it? if my heart rate is good and my blood pressure is good, right? Yes. We're going to assess the apical pulse for 1 full minute. And we're going to hold it, not give it, if the heart rate is less than 60. Okay? Now, when I say that, you're going to have providers to write parameters for this medication that may be less than 60. I have seen some write less than 50. So as you're giving your medications, make sure in your free checks that you are doing that you hover over that medication and you see if there is a parameter already written. May give if heart rate less than 60, but greater than 50. Okay? There's some pointers that you need to be mindful of. I need to know the signs and symptoms of toxicity. Can this medication make me sick? Again, I can become toxic from it. How can I become toxic? I have too much in my bloodstream. So these are the signs and symptoms of DIG toxicity. What's the most important? Because that's what the medication does to my body. It slows my heart rate down, right? So I need to watch this patient for bradycardia. Big thing. Now, you will have patients come in that are taking this medication. If you're in the room with them and they say, man, my vision, when I look at the lights, they look yellow and green. Take note. They also can see or be nauseous and vomiting. Kind of a side effect for a lot of medications, right? But this one's important. They're also going to become anorexic. What do I mean by anorexic? They don't want to eat. They don't want anything to eat. They can become confused and even get delirious from this medicine being toxic in their system. So those are nursing considerations that I need to be mindful of as I'm giving this medication. Make sense? Okay. Now, let's make it an ISFAR situation. I'm Nurse McCard, taking care of your patient, Mr. Jones, in room 202. I noticed to the physician as I'm talking that his heart rate is 52. And he's telling me that he's seeing yellow halos around the lights in his room. He also has not eaten anything all day. It says he is so sick to his stomach, he doesn't think he can eat anything. His DIG level is 2.8. What are you thinking? What do you think's wrong with him? He's DIG toxic. So what do we need to do with that medication? What's our recommendation? Do you want to hold this medicine? Do you want him to have it? And they're going to say, no, we need to hold it. Now this drug has an antidote. Remember, Ms. Curley talked about some antidotes last week. Called Digibond. When you give Digibond, it's going to bind up with the dig in the system. We're not sending the system. It's going to pull it back, it's going to dump it. What dumps? Where does this filter? The kidneys. So if I have a patient, a critical thinking moment, that has acute kidney injury, acute kidney failure, chronic kidney failure, do I need to be mindful giving this medication? Yeah, I sure do. Okay. Digitalis toxicity, important to remember. Because you're going to be taking care of folks that this can happen to. Factors that predispose toxicity, we just said kidneys for the tox filter. Kidneys aren't working, it's not getting out of the body, right? Hypokalemia. Potassium, I can't increase that force of the heart. Can I? No. And we need to be mindful that when we give this medication, IV, that you need to give it slow. If you give it too fast, because it drops their heart rate, it drops their blood pressure. What am I gonna do? I'm gonna drop it even further. So I need to be mindful of that as well. Okay. What am I gonna teach them? If I'm giving, if I'm gonna give you a medication that's gonna drop your blood pressure, drop your heart rate, what do you need to teach this client? How to take them. Where's the best place for the client to learn to take their heart rate? Right here. Okay. Or carotid, but don't do both at the same time. We need to teach this client foods high in potassium. What's high in potassium? Bananas. What else? Oranges, tomatoes. So just be mindful of some foods high in potassium. I need their potassium level to be in the normal range, right? So that we can get the effects of the medication. And nursing consideration, most important. I need to know what the signs and symptoms of toxicity of digoxin. Did I say digoxin? Digoxin. I got two questions and linoxin. And we go through first and we'll continue. Yes, ma'am.
When you meant, you would go through IV administration, you meant like a slow rate.
It's an IV push,
IV.
and you will be given a small dose IV push, but we won't be given IV push medications right now. What? It will drop the blood pressure, and I'm not sure I heard your whole question.
Okay, that was it.
That was it, yes. Okay, so what does nursing have to do? Assess what? Blood pressure and what electrolyte? Potassium. Good job. How many patients have you seen since you've been in clinical have renal impairment? A lot. What group of patients have you seen have renal impairment? Diabetic patients, congestive heart failure patients, dialysis patients. Are there potassium dialysis?
Yeah.
Yeah. Okay. Yes, ma'am.
It's just a medication that patients can get home.
Yes, it is.
So with maybe their 12 months withdrawn, medications.
They should periodically. At the bottom. Especially if you're concerned that there's any toxicity.
Whether in the hospital or if they're not being done.
There should be. Should be. So we're in clinical. We're fixing to give the Johnson. We're gonna give it PO. What do I need to know? What do you need to know?
Their serum.
Serum level. First thing. Well, not the first, but one of them. Blood pressure and heart rate. And their what? Potassium level. Good job. So why should the nurse assess an apical heart rate for 1 full minute? We want to know what that accurate heart rate is, right? Yeah. How will the nurse evaluate the effectiveness of digoxin? How do we know that it's working when we give it? Check the heart rate. It helps strengthen that contraction. How do we know that? It also will decrease the heart rate. It also will decrease their blood pressure. But we're given this medication for what reason? Sick heart, right? Heart failure folks. So we want to see signs and symptoms of improvement with heart failure. Okay. Does that make sense? Yes, Ms. Picard. Okay. Why must the nurse monitor the serum potassium levels as well as the digoxin levels? So we need to monitor serum potassium. Why? Because that potassium helps with the contraction of the heart, right? Why do I need to know the dig levels? We don't get too much. So we're not giving it if they're toxic, right? Okay. Now you tell me what signs and symptoms of dig toxicity is. Bradycardia, like it.
The yellow and green.
yellow and green halos,
nausea, vomiting,
nausea, vomiting,
Anorexia.
delirium,
and anorexia.
anorexia, and confusion. You got those on your paper? Gotcha. Okay. Questions? I love animals. Questions? Yes, ma'am.
Why did you say, I didn't catch it, why do you need to know the digoxin levels?
Because this medication works on a therapeutic level.
Mhm.
0.82 mg per milliliter.
Okay.
So I need to be within that window.
Mhm.
And that will help me know that I have enough in my bloodstream to help my heart for the purpose of this treatment. Make sense?
Mhm.
Okay. Questions about this? Good here called bitch, digoxin or lanoxin. Yes, ma'am.
I read somewhere that shows that they don't give it so much, or they try not to give it, especially the solid dose. That, like, you can still give it a lot in clinical practice, or not?
I would say, and this guy can help me with this one. I would say that it depends on the provider that's giving the medication and the reason that the medication needs to be given. If that's somebody with just a sick heart, I need a little more force to decrease that workload. Good medication to give. But if there's other issues going on, then we might consider something different. Agree? Any other questions about this medicine? I'm gonna move on. Antihypertensives. Why are we giving antihypertensive medicines?
High blood pressure.
Decrease the blood pressure. So we need to do what? Check their blood pressure, right? If you are with me in clinical, you know by now, I've had some of you extra. If you come to give meds, I'm gonna say, do you know what the blood pressure is before you give that medicine? And what do you say? I sure do. Blood pressure is 132/78. So we're good to go, right? Okay. We're giving it antihypertensive medicines because we want to decrease their blood pressure. Big reason. Can your client take more than one blood pressure medicine?
Yes.
How many patients have you given 3 different blood pressure medicines to? We did that yesterday. They all work in different ways. We're going to talk about those. So we need to know the different classes. I'm going to go over those. That's on your homework page. What do you need to teach your client about these medications? It's going to be an important thing before they get ready to go home. What will you need to know before you administer these? I've already said we need to know their blood pressure, right? Okay. How do they work on the body is important as well. Because how they work on the body is how, what receptor cell it's going to affect to make the blood pressure come down. I'm going to pull from your brain back to anatomy and physiology. So we said our vascular system squeezes to make our blood pressure go up, dilates to let our blood pressure go down. What other systems help our blood pressure? Kidneys. What did you say first? Renal, kidneys. How do the kidneys do that? So our kidneys filter, but our kidneys also have enzymes in them. Part of the renal angiotensine aldosterone system. I'm going to slide you a video we're going to watch in a little bit about that when we get to ACEs and ARBs. So when you look at this slide, these are things that you need to be mindful with antihypertensives, okay? Where are our alpha cells? We said this earlier, remember? Yes. And our vessels, dilate, constrict, dilate, constrict. When we give these medicines, we want our vessels to work differently. Clonidine, everybody say clonidine, is one of the medications that is an alpha 2 agonist. What's an agonist?
It helps.
It
Yeah.
helps. Very good. What's an antagonist? It doesn't, it blocks. Two words that if you can get in your vocabulary will help you with some of these medications. So write those down somewhere. So alpha 2s stimulate the alpha adrenergic receptors. We're going to talk about adrenergic cells in a little bit, causing vasodilation. And what's that going to do? Decrease our blood pressure. It's also going to help with peripheral resistance. If I open up my vessel, they're not having to work so hard, right? Okay, blood's going to move. And I'm going to increase my blood flow to what organ? My kidneys are going to be thankful. Nursing considerations with alpha 2s. If I'm going to drop my blood pressure, what do I need to monitor? Can also adjust your heart rate. So I need to monitor that too, right? If I say I need to monitor the heart rate, how do I need to monitor it? Actively. Nursing needs to teach these clients. Most antihypertensives don't stop taking your antihypertensive medicine abruptly. Because if this medication is working to decrease your blood pressure, and you stop taking it, what's going to happen? Your blood pressure is going to run sky high. Take this medication same time every day. Take it as prescribed. As your provider says, take this medicine once a day. Make sure you're taking it at the same time because we need to keep those levels in the blood up there. What's orthostatic changes mean? Who was with me in clinical Tuesday? And we had a client with 3 different blood pressure medicines. And this also happened yesterday. But Tuesday, this client was sitting on the side of the bed and we walked into the room and we were fixing to give her a handful of medication. And when I say handful, 18? Yeah. What? 18 different medications. 3 of those are antihypertensive medications. They're all different. And they work in different ways in the body. And she was, do you want to share, Sean?
Okay, yeah. So she was sitting on the side of the bed and then she kind of just let us know that she was feeling dizzy. And then we were like, all right, well, we'll grab a vital machine, take your blood pressure. So we did. And it seemed normal. I mean, it wasn't like too low, too high. It seemed pretty normal. So then she said she had to use the bathroom. So we got her, well,
She was sitting on the side of the bed.
she was sitting on the side of the bed, and then when she stood up, her blood pressure dropped, and then she nearly passed out on the card, and then, go ahead.
So in my mind, I know Sean was getting her medicines ready. Fixing the scale, she's over there doing her job. We've already talked about all these medicines. And in my mind, I'm thinking, we got 3 different blood pressure medicines. What if we have a lady that's dizzy? Her blood pressure when she was sitting down was 132 over the 70s. Oh, okay, I like that. But then the next thing she said to me is, I need to use the bathroom. I need to get up to the bedside question. She's not going in the bathroom, right? Good decision. Because I didn't have a problem. So I read the bedside question. Okay, then pivot and sit. She stood up. She got really dizzy in her eyes. Like, and she just kind of fell backwards onto the bed. And she sat there. So we got her position. Check her blood pressure again. I don't know what her blood pressure was when she was standing. The orthostatic changes are when you are laying, sitting, or standing, there's a difference in your systolic and diastolic pressure. Guess what happens? It starts up here. When you stand up or sit up, it goes down here. And they can pass out very quickly. When we're in facilities, we don't want our people to fall. So they were trying to be very mindful. We ended up giving her medicines and she ended up being okay. But be mindful. When you say this word, orthostatic changes to your patient, do they know what that means? So we need to teach them to monitor their blood pressure, right? If I think they might have orthostatic changes, how do I want them to get up? Very slowly. So change positions slowly. Makes sense. Okay. So with this medication, clonidine is an example. These doses may need to be adjusted as we go along. We start out with a bigger dose, working my way down to a lower dose. Because the effectiveness of an antihypertensive, how do I know it's working? Dropping my blood pressure, and this one can drop my heart rate. So if those two things are happening, they need to let the provider know, hey, you know, when we started this medicine, my blood pressure was like 160 over 100. Now it's like 120 over 40. So they need to keep a log of their blood pressure so that they can go back to the provider and say, this is where I'm at. Make sense? Yes, sir? I'm seeing yeses.
I do have a question.
Yes.
So you said that they're gonna gradually lower the dose as the blood pressure is lowering. Is that how they kind of find like that sweet spot of what their actual prescription will be to maintain that blood pressure?
That is a correct statement. We may not change the dose at all because blood pressure stays up. But as our blood pressure trends down, we may need to change it. Number one, because it's working. Number two is we don't want a lot of this. We don't want them falling. Especially if they're taking an anticoagulant. We don't want them falling on it, right? Good question. If you guys in the back cannot hear the questions, ask and I'll repeat them. Questions? No questions, so we're good. Okay. Beta blockers. This is one you're going to see a lot of. Beta blockers. There's different types of beta blockers. But what I need to know about beta blockers is beta 1s. If they're blocking beta 1 receptor cells, where are those? My heart. If I'm a beta 2 and I'm blocking, I can affect my lung, right? Remember this picture because it's going to help you with beta blockers. So beta blockers will also decrease the heart rate. So what do I need to know before I give the beta blocker? Heart rate and blood pressure. Everybody say with me, metoprolol. It has another name, which is low pressure, but there's different forms of metoprolol. So we're going to say metoprolol and be done with it, okay? What does that word end in? Law. Law. O law. A law and I laws are your suffix for beta blockers. Why am I going to give this metoprolol? Because I have hypertension, right? That's what we're talking about, antihypertensive. This medication can also be given for folks who have angina, chest pain, and also to folks who have poor blood flow to the heart, and also for tachycardia. But for pharmacology today, I need to know that this medication is given for hypertension. Okay? This is a medicine you will see a lot of. Okay. What does it do? How does it work? It decreases the workload of the heart by blocking the beta 1 cells and allowing the heart to work more efficiently. So that should be on your homework paper. Sympathetic nervous system. You have that on there? SNS? Should. So not only the heart rate, but the what? The apical heart rate. When am I going to hold it? Heart rate's less than 60. Adverse reactions or adverse effects of beta blockers are shortness of breath, I'm given something that can drop my blood pressure and drop my heart rate. What is bradycardia? My heart rate's low, so it's 60 or less. And worsening heart failure symptoms. Because this medication affects the receptors in the heart, it can worsen if I give too much heart failure symptoms. Okay. What do I need to teach my client? Don't abruptly stop taking it, right? With antihypertensives. I need to taper this dose before I stop it. So you need to teach your client that they need to talk to their provider about this medication. How many folks have you seen? They get their prescribed medication and say, my life goes on the side. They're helping their blood pressure. So encourage them to talk to their healthcare provider. And this medication can also cause erectile dysfunction in males. There is a black box warning for beta blockers. Don't take it while you're pregnant, and don't take it while you're breastfeeding. Right. So y'all are going to see examples of beta blockers. OLs, ALOLs, and the ILOLs. The OLOL family. Okay. Everybody with me say atenolol. Other name for that is tenormin. Tenormin. Atenolol. I know that we've given carvedilol in clinical. So everybody say carvedilol. The other name for that is Kodak. Correct. Propranolol. Other name is Inderol. And when I have non-selective written here, that's just the beta 1 cells, non-selective. So evidence-based research says beta blockers can be given also for heart failure to prevent dysrhythmias. Okay. Why do I need to know that my patient's taking this medicine today for pharmacology? Antihypertensive medication. But just remember that these medications can do different things on the body. Okay. Here's its action. Blocks the sympathetic nervous system. We're going to talk a little bit more about that when we talk about adrenergic meds. Because we're going to bring back up beta blockers. Okay. Yes, ma'am.
The propranolol said it's not what you mean.
That it affects just the beta 1 cells. And we're going to revisit that when we go to adrenergic meds in just a little bit. We'll go to that PowerPoint. We'll talk about that non-selective and selective. Okay. Any other questions? Beta blockers. Do you guys need about a 5-minute get up, walk around, clear your mind, come back? Okay.
Yeah.
All right. Now's the time for questions if you have questions. Can you ask me questions about any medication that's covered? Any questions about beta blockers? Are you good thus far? Because there are a lot of medicines. Okay, that's your study sheet right in front of you. If you completed it, that's going to be a big jump on study. Okay, moving along. Calcium channel blockers. Note, a lot of these say blockers, right? We need to block something. Beta blockers block in what cell? Beta cell. Where's beta cells? Beta 1,
one.
beta 2, lung. Okay, calcium channel blocker. What does calcium do for the body? Calcium increases the workload of the heart. It increases myocardial contraction. What is myo? Muscle, right? Muscle part, myocardial. Heart's a big muscle. It also, calcium increases the workload of the heart. So if I have a sick heart, or having somebody that's come in to the emergency room, wherever, and they're having chest pain, do I want calcium to be working really hard? I want to decrease that, right? So they need, if the provider chooses, calcium channel blocker, okay? Calcium channel, CC blockers, decrease the myocardial, what does it say? Contractilities, the squeeze, right? What was that word over here? Okay, so I'm decreasing, if I give a calcium channel blocker, that contractility, so the work doesn't have to work so hard, right? It also eases the workload of the heart. Why do I want to do that? So I can increase that workload so I can get that oxygenated blood to the heart, right? Yeah. What is this medication going to do to my heart rate and blood pressure? Decrease it. So what do you need to know before you give that medicine? Heart rate, what kind? And the blood pressure. It also, this works by relaxing the smooth muscle and causes vasodilation. So there you go. What's vasodilation do to my blood pressure? Drops it. Okay. We learned back way back when, heart's a huge muscle. You will be surprised at the patients that you're going to come across that doesn't know or don't know that that heart not only we do get the blood moving, it needs blood itself to function. Several purposes for that heart, right? Okay. So nursing considerations for calcium channel blockers. Everybody say with me, verapamil. That is a type of calcium channel blockers. Nifedipine. Diazepine, wait a minute, diltiazem. Different drug. And amlodipine. What do I notice about PINE on two of these? They're suffix for calcium channel blockers. That'll help you know that if that drug or that medication ends in PINE, guess what it is? Calcium channel blocker. Okay. So we know that we need to assess the heart rate and the blood pressure. The key cutoff point is hold for systolic less than 90. Now, I'm going to jump back over here on this box. Could there be parameters the physician has written? Yes. So I need to be aware of that before I get this medicine. Yeah. When we get these heart antihypertensive medicines, we're working with the heart very closely. So we want to decrease that workload so the heart doesn't have to work so hard. So they need these medications, right? We need to be assessing our folks very thoroughly. What are we going to teach our clients? How to take their heart rate. Above that, you will see calcium channel blockers can be given for atrial fibrillation. Do y'all know what that is yet? Yeah. Some of you, yes, maybe, but you don't have to know what that is. It's an irregular heartbeat, heart rate. So just be mindful. The big key is it's hypertension. That's why we would be given a calcium channel blocker. It also can be given for angina. What's angina? What's the other name? Angina pectoris, chest pain. Where do we want to cut off for heart rate? Client teaching to take heart rate and report a heart rate less than 50 to who? Healthcare provider. How do you think this client's going to feel if their heart rate's really low? Dizzy. They could feel anxious. They could feel really drowsy and not good at all, right? If your heart rate drops, you get sick to your stomach, right? Okay. It can cause dizziness and visual changes. What do we also want to teach them? For what reason? Orthostatic changes. Avoid grapefruit juice. Who ever heard of such? Why? Okay, so calcium medications, calcium channel blockers, and grapefruit juice don't work well together. Why? Because grapefruit juice interrupts the function of calcium channel. So can I have grapefruit juice and take a calcium channel blocker? No. Can I drink my grapefruit juice in the morning and take my calcium channel blocker at night? Yeah. Yeah, I can. Something you may want to teach your clients. Just don't take it within 2 hours of each other. Monitor for gingival sensitivity. This medication can cause them to have gingival changes in their mouth. What's gingival? Gums. Do we want to teach them? Maintain good oral hygiene. Brush your teeth. Rinse your mouth out. If you have such changes, who do I need to notify? Healthcare provider. Take your medicine as prescribed, right? Yes. Questions about calcium channel blockers? What's it going to decrease? The workload of the heart. Decreasing what vital signs? And heart rate, blood pressure and heart rate. What do I need to teach these clients? How to take their heart rate and how to monitor their blood pressure. What else do I need to teach them? Don't take the grapefruit juice, but there's one other more important thing.
Change positions slowly.
Change positions slowly. Okay. Let's talk about the RAS system. Don't let this word intimidate you. Renin. What is renin? It's a hormone, right? Where is it at? In my kidneys. Renin angiotensin. Where's that enzyme? In my kidney. Aldosterone. It's the kidneys. Where are these mats going to work? Kidneys. So your body is a phenomenal organ. It's going to note that your blood pressure or your blood volume is low. What happens during that? Things begin to drop, right? Blood pressure, specifically. The body notes that. So what does it do? Tells the body to release renin. What does renin do? Tells the body to hang on to fluid, right? Angiotensin 1 is released from the liver as well. So these things are noted when you have volume depletion or low blood pressure, and these hormones and enzymes are released by the body to help do what? Bring up that blood pressure. So then we convert angiotensin 2 to an angiotensin converting enzyme, so we can keep that blood pressure up, right? What do our adrenal glands do? Where do they sit?
Like above the kidney.
On top of the kidney. So they secrete also another hormone. You remember what they are? Epinephrine and norepinephrine. We're gonna talk about those. But our adrenal glands secrete aldosterone. Where's water and sodium? How does that work together? Sodium follows the water, so keep everything inside, so our blood pressure stays up. Kind of making sense. So if I save the sodium, what am I saving out? Water. So I'm having the volume in my body. So I'm increasing and keep trying to keep my blood pressure up. So then I have another one. Where's this one? Up here in the noggin, right? Secretes ADH. Antidiuretic hormone. Antidiuretic hormone. What's diuretic? We want somebody to pee, you're at fluid, right? If my blood pressure is low and I don't have enough volume, do I want to pee? So then my body knows. Tells my pituitary gland, secrete this hormone. The no pee hormone is what I call it. Okay? So all of this reestablishes my blood pressure. Keeps my volume up, sodium and water. Does that kind of make sense? Phenomenal organ? Yes, ma'am.
With this system still kicking in, crazy, or does it block like part of it and the rest of it?
All right, calcium, if I'm taking a calcium, let me see if I got it. If I'm taking a calcium channel blocker, will this system still work? Is that your question?
Yeah, because I know calcium is part of it, but then does the rest still keep going?
So if I'm taking a calcium channel blocker, yes, this system still works because calcium channel blocker is blocking what? Calcium. But the body has the system in it. Phenomenal system to help keep my blood pressure up, keep my volume up. That's the basics of this. Okay. So I'm going to post a video. It's less than 5 minutes that explains this in a different way. Not a different way, but somebody else's way. Those of you that were what it helps. Okay. So my body knows that my blood pressure is low, and say I've been sick, I don't have enough iron. I'm hypovolemic, right? Who starts working? The RAS system. What's the first thing? Kidneys release renin. Renin says, okay, body, you need to hang on to some fluid. So the angiotensin 1 does what? Is released from the liver, so it keeps my blood pressure from dropping, converted to angiotensin 2 by the ACE. Adrenal glands do what? Secrete aldosterone, which does what? Saves sodium so that my body keeps my water. Y'all said sodium follows water? Or water follows sodium? Water follows the sodium, right? So we're going to save my water, save my volume. The pituitary gland secretes the ADH, antidiuretic hormone. I don't want them to get rid of volume, right? No, I don't. So it reestablishes. Here is a picture, and this picture is in your book. So I have renin in where? Kidneys, right? And the angiotensin here in my liver. So here's the bloodstream. This my volume drops, so it starts converting all these enzymes and starts telling my body, hold on to that fluid. Okay. This picture is in your book. It is a retake of what we just talked about. So have hypertension. And the provider says, well, we need to give you an ACE. What's an ACE? Angiotensin converting enzyme. Why do I need that? I need to decrease my blood pressure, right? Okay. Prils. These words have a suffix of P-R-I-L, pril. Captopril, say that one. Lisinopril. How many have seen lisinopril? Monopril. Just examples. ACE action is to block that conversion of angiotensin 1 to 2 in the RAS system. That's why you need to know what goes on in the RAS system. Okay. What does all this do? Leads to vasodilation. We'll make it be quiet in a second. And get on the sodium and water. And it blocks aldosterone. What was my aldosterone?
It's released by the adrenal, to
Regulate sodium
regulate
saver.
It makes your sodium saver. Good job. So if I give an ACE, I'm going to decrease their blood pressure. That's all. Nothing else. No effects on the heart rate. Okay. So what do I need to assess before I give a pril? Blood pressure. Used to treat hypertension and heart failure. Okay. The reason it's blocking this angiotensin 2 is because angiotensin is a protein. Exactly. Good job. Okay. Are we good? Moving along. So there always has to be a nursing consideration when I give medications, right? I have to think about why I'm giving this patient this medicine. What's the action of this medicine? What do I need to teach them? Don't take while you're pregnant. Can't. It can cause deformities in your babies. Cautiously with clients that have diabetes. Have you heard? Do you know how diabetics blood vessels are?
They're like hard.
They're very narrow.
Oh, narrow.
You want to be cautious when you give it with renal patients. It works really well because all that RAS system works in the glomerulus of the kidney. So when I say cautious, I want you to be mindful that when I'm giving this medication, it's going to work really well. I need to note that blood pressure. I need to teach that client to take their blood pressure and keep a record of it. So if this medicine doesn't work, what do I need to do? Notify my provider. Yeah. Now, one of the biggest things with ACEs is a persistent, hacking, dry, non-productive cough. That is something you need to let somebody know about. Who's that somebody? Healthcare provider. If I develop this, it can turn into something more. So they need to change this medicine to something different. Make sense? Okay. Assess for facial swelling. What is that? An allergic reaction. So if facial swelling happens, it can happen so bad that their tongue gets so large and their face swells up so much that their tongue is protruding from their mouth. Is their airway protected? No way, not at all. So these are two huge nursing considerations. Yes, ma'am.
The reason that we would watch this with this medication specifically, when you have facial swelling and an allergic
You can have allergic reaction to anything. But for this medication specifically, angioedema is one of the big things nursing needs to be mindful of.
So it's not your fault.
It's not what?
It's not anaphylactic shock.
It's angioedema. It's not anaphylactic shots. That's a whole different, all right. Okay, so what happens when I get angioedema, my tongue's protruding from my mouth? You think I have trouble breathing? Yeah. Yes,
So you can't take it while pregnant, but can someone who's breastfeeding take it or no?
it's not safe. Not safe. So being that while you're pregnant, you don't want anything to happen to your baby,
Anything breastfeeding?
it passes along through breast milk.
Okay.
You don't want anything to happen to your baby. Did y'all hear that question?
Yeah.
Hyperkalemia. Have y'all ever picked up a salt substitute in the grocery store and looked to see what's in it? Instead of sodium chloride, it's potassium chloride. Oh. Next time you're at the grocery store, pick up one and look and see. This medication, you need to know what is kalemia. Potassium. So before I give this ACE, I need to know what their potassium level is. If it's high, I'm not giving it, right? I need to call somebody. Make it an SMAR situation. Hyperkalemia, avoid salt substitutes. So do I want to teach this client to avoid foods that are high in potassium?
Yes.
Yeah, be mindful of what you're eating. Boy, isn't it hard to be mindful of what you're eating? Yeah. Yeah. All right. Now, there's another medication, ACEs and ARBs. What's an ARB? Angiotensin 2 receptor blocker. It's another antihypertensive medicine. Good grief, how many are there? A bunch.
Right.
Yeah. So these medications have the suffix of sartan. Okay? Losartan. Say the word. Losartan. Valsartan. Arebasartan. So ACEs and ARBs are kind of the same, but they work in different places in the RAS system. This one blocks the angiotensin receptors. What's it going to do? Lower my blood pressure. Okay, antihypertensive. ARBs act on the RAS by blocking angiotensin 2. What does it cause? Vasodilation. Do I need to worry about peripheral resistance? No. I just need to know that this is an antihypertensive and that this medication works by blocking angiotensin 2. So it's going to blood vessels to dilate to decrease my blood pressure. Is that making sense? Okay. This one can cause that cough that we talked about for ACEs. More important with ACE than ARB, but it's still possible it can happen. So you need to go ahead and teach your client. You develop a persistent, dry, hacky, non-productive cough. Let your healthcare provider know. Okay? Wow. If I can't take ACEs while I'm pregnant, can I take ARBs? No. It's going to alter my kidney function, right? I don't want to do that while I'm pregnant. It can also cause deformities in your unborn child. So because angiotensin was secreted from what organ? Liver. What about your folks with hepatic impairment? Need to monitor. Before you give this medication, what's Ms. McCarr going to ask you? Do you know the liver enzymes? AST and ALT. Why do I need to know that? Because if I give this medication and they're in hepatic problems already, possibly hepatic failure, can I damage them even more? Mm-hmm. Absolutely. So this one, ARBs, can cause renal impairment and hyperkalemia. Kind of the same as the ACEs. What do I need to teach my client? avoid salt substitutes because they're potassium chloride, right? Are y'all making sense in the paper? Yes. What do I need to look for before I give it? Assess blood pressure. Just the blood pressure. Doesn't do anything to my heart rate at all. So I need to make sure my blood pressure is low. What's going to happen? How I feel. Dizzy. I also think called that angioedema. I see more folks in practice with ACEs and angioedema than I have with heart. I'm not saying it can't happen, it can. What do I also need to teach them? Don't stop this medicine abruptly. If I do, what happens? Shoot your blood pressure up really high. What else do I need to teach them? Get up slowly. Change position slowly. ACEs and ARBs are two that just decrease your blood pressure. Antihypertensive. Okay. Caution chart. My words want to bind together. Caution your clients to change positions slowly. Lovely critters. Questions? Yes, ma'am.
What were the liver enzymes called?
AST and ALT. Some facilities will call it something different. SGOT and something that with another SLOT. But just remember AST and ALT. Okay?
And so the edema, that's not like, if somebody's having that, that's not an allergic reaction, that's a side effect.
It is a side effect, a severe.
It's a
adverse
severe,
reaction.
yeah. But it doesn't mean that they're allergic.
Doesn't mean they're allergic, but it makes their face swell. I have seen folks, their eyes swell shut, and their tongue protrudes, they cannot get any air in their mouth at all. Look it up, Google it.
Yeah, I did, I know it was.
Yeah, pretty bad. All right, are we good? If we have enough time, I have a game for us to play. Yay. So let's ask some questions. I have to look at the board because I don't remember these word for word. So I have a client who's 79 years old, or she is, who has lived alone for the past 5 years. So what I want you to do is recognize cues. Do you know what I mean when I say cues? Things that jump off that to you. 79 and living alone. Okay. 3 years ago, this client was hospitalized for a heart attack. Do you know what a heart attack is? Kind of, sort of. Heart attack means that the vessels that surround the heart, that feed the heart blood, has a blockage. Bad thing. Good thing. So when you have a heart attack, you can end up in heart failure because your heart's weak, right? The client is compliant, it's a her, with her medications, which include what? Digoxin, another name, Lanoxin, and she takes 0.125 milligrams. What's PO mean? By mouth. How often? What else does she take? What's the other name? She takes 40 milligrams PO daily. What is furosemide? You know what that is? An antidiuretic to make her pee, right? And she takes potassium, 20 MEQs. What's MEQs stand for? Milliequivalents, PO daily. So when I take a diuretic, what electrolyte do I get rid of? Most potassium. Do I need a potassium supplement? Do I need to know what my potassium is before I give it? Sure do. Okay, so let's carry on. Recently, she ran out of her potassium and thought that because it was just a supplement, it would be okay to go without it until the next time she went by to fill her other prescriptions. Is that cute? Yeah. So she's doing without her potassium. She's not taken her potassium in over a week. Today, she comes to see the healthcare provider at the clinic with generalized weakness, fatigue, nausea, diarrhea. What are those cues of? What other meds is she taking? Digoxin. There's jumping off the paper at you? Or what kind of reaction to the digoxin? Toxicity. So her vital signs are 104/62, good, bad, or ugly. It's okay. Her heart rate's what? 52. Does that one jump at you? Is that low? It's called bradycardia, right? Her respiratory rate is what? And her temp is that okay? Yeah. She's had blood drawn. She has a serum sodium of 150 MEQs per liter. Is that good? High or low? Okay. She has a ditch level of 2.6. That should be the big red flag right there, right? And a potassium of 3.2. That's low. A low on the low side, right? So, what am I thinking? What's going on right here? You said it. What kind of toxicity? Ditch toxicity, because I have the signs and symptoms. That's the medicine I take, and my level is high. What's the high normal? 2. So what is your assessment of the situation? Ditch toxicity, right? Okay. What are signs and symptoms of ditch toxicity that she has? Weakness, fatigue, nausea, diarrhea, and the high ditch level, right?
In the bradycardia.
And the bradycardia. Good job. What are the normal ranges of sodium and potassium? Do I know? Sodium is 135 to 145. Good job. What's my potassium normal? 3.5 to 5. Am I good? I'm high on sodium, right? Okay. What would be a recommendation for this client? Antidote. What's the name of the antidote? Digibide. Good job. Does that help? Yeah. All right, here's another question. Client has a history. The following medications have been ordered. Metoprolol, what's that one? Beta blocker, 100 milligrams. That's a big dose. 25 to 50 is the normal. Lisinopril, 5 milligrams. What's lisinopril? ACE, hydrochlorothiazide. Have you seen that one? HCTZ. It is a combination medication of an antihypertensive and a diuretic. So how many antihypertensives am I on? 3. Okay, there's cues. So this client has a history of hyperlipidemia, hypertension, and coronary artery disease. Client asked the nurse, why do I have to take all these medicines? What are you gonna tell them? What am I gonna tell them? Why do you have to take, and you're gonna get asked this question, give a minute. Why do I have to take all these medicines? They all work differently in the body. Okay, does it make sense? Okay. So that's your best response. You need it to decrease your hypertension, antihypertensives, and they all work differently in the body. Help? All right, let's do 2 more and then we'll move on. Client is receiving digoxin for treatment of heart failure. What do we think heart failure was? A weak heart. Good enough. Which findings would suggest to the nurse that the heart failure is improving? Pale and cool extremities? No. Absence of peripheral edema? Yeah. Probably a circle around that one, I'm not sure yet. Urine output of 60 milliliters every 4 hours? That's normal, right? Yeah?
Isn't it supposed to be like 1 milliliter?
So what's normal? 30 every hour is the minimum, okay? Complaints of increasing dyspnea. What's
No.
dyspnea? Shortness of breath. So can I X this one out?
Yeah.
Can I X this one out?
Yeah.
I'm not really sure which one. What am I giving the med for? Make the heart stronger, right? I'm giving it for heart failure. Perfusion. Does digoxin have anything to do with the kidneys? No. Okay, one more. So the client's serum dig level is 3. Right, what's wrong? High. What's normal? Got it? 0.8 to 2. What does the nurse know about the serum dig level? It's high. Hey, agree? Any naysayers? No? Y'all can naysay. We'll discuss it. Let's get out to one more. I like questions. Helps you put what we just learned. Patient taking the initial dose of a nitrate. What's a nitrate do? Vasodilates, right? So what's it gonna do to my blood pressure? So I'm thinking my way through this question before I read it all. So I know that this nitrate is gonna decrease my blood pressure, right? Okay. Which side effect will the nurse expect to occur? Nausea, vomiting? Yeah, maybe. Let's read the rest. Headaches? How many headaches? Stomach cramps? No. Irregular heart rate? So headache, why headache? Because of vasodilation. Good job. All right. You are. I'm gonna stop this one. I can put some more questions up there. What do we say the word agonist means? It helps, right? What do we say antagonist meant? Blocks, doesn't help. So let's talk about some of these adrenergic medications. Thank you. So this PowerPoint is going to talk about the 2 groups of medications that affect the sympathetic nervous system. We said earlier what to epinephrine and norepinephrine. Okay. This picture is in your book. Boy, that's a big picture. Seven nervous system, quick review. Okay. Have a central and a peripheral. We said earlier, a lot of the medications that we talked about, antihypertensive medicine dilated my peripheral vessels, right? And also my arteries. So, peripheral nervous system have motor and sensor. What does that mean? Motor says I can move, and sensory says I can feel it. Remember the old story, it touches the pot? Story says move your fingers, right? Autonomic, that's somatic. Some of these medicines are going to work on the autonomic nervous system. Sympathetic and parasympathetic, 2 biggies. Sympathetic has alpha 1, alpha 2, beta 1, and beta 2. We talked about those. Parasympathetics are this group over here. I believe that Ms. Curley talked about some of them. Yes. Okay. This picture is in your book. So here again, autonomic nervous system. We'll talk about sympathetic nervous and parasympathetic. They divide in two. So you'll see S and S for which? Sympathetic, PNS for parasympathetic. Where's all this? Brain of my spinal cord, right? Motor and sensory. By motor, that means it's coming from the brain to tell the body to move. Sensory, the body's saying, hey, that's hot. Sends a message to the brain, right? This is all review, folks, from A&P. Okay. We will come back to this one. So, my sympathetic nervous system is what's known as I'm either going to fight you or I'm running because I'm not fighting. Sympathetic nervous system is going to prepare me to fight. So what do you think sympathetic is going to happen to my vascular system?
Yeah,
Sympathetic. You think it might constrict?
Oh, yeah. Raise blood pressure.
Got it.
Yeah.
It's going to prepare me. On the previous slide, you'll see all the systems in effect. No, I'm going to stay and fight to speak out. I'm running flight, parasympathetic. Makes sense so far? Maybe? So in the sympathetic nervous system is responsible for fight or flight, as we said. Adrenergic system is the group of organs and nerve endings on to adrenaline, epinephrine, or noradrenaline, norepinephrine. And they're neurotransmitters coming from the spinal cord, brain, telling the body what to do. Fight or flight. Are we staying or we leaving? Are y'all with me?
Is that another word for sympathetic or is that a different thing within the sympathetic nervous system?
Because adrenergic system secretes these two. That's where I want you to keep adrenergic, epinephrine, norepinephrine.
But is it
It
located?
is part of the nervous system. Did that answer your question? But which one? So we say this is sympathetic, right? Yeah. This prepares me to flight. I hate spiders. So when I see a big spider, this is what happens. Epinephrine. This is freedom. I'm calming down, life's good, going down, and the norepinephrine kicks in, helps me calm down. Okay? Are you with me? Okay. Okay. Part of the sympathetic nervous system. Wrong slide. So here's what happens. Sympathetic nervous system secretes adrenaline. My pupils will dilate. I have bronchial dilation. What's bronchial dilation?
Your airways.
Airways open up so I can breathe, right? Tachycardia, what's that? Heart rate goes up. Blood vessels constrict. And a relaxation of a GI system. And relaxation of the bladder. So I gotta go pee if I get really nervous, right? So epinephrine in this way works to the body. Hang tight. What happens with parasympathetic? Rest and digest. It is the opposite of. We're going to talk about beta blockers here in a minute, and you can relate it to all of that. So hang with me. So what do you think my responses to parasympathetic are? Just the opposite of the sympathetic, right? So constriction of pupils, constriction of bronchioles, decreases the heart rate, dilates the blood vessels, increases peristalsis, and all of these are on your slides. and constricts the bladder, but it also increases saliva. All right, I'm gonna jump. Catecholamines. We talked about alphas and betas earlier, right? What alpha-1 drug did we talk about? Clonidine, something there? Okay. What betas did we talk about? Beta blockers, beta-1? Metoprolol, okay. So catecholamines is your epinephrine and your norepinephrine that we just talked about. Affecting epinephrine and norepinephrine are both adrenergics, part of the sympathetic nervous system. It works epinephrine on both alpha and beta. Where is alpha cells? Blood vessels. Okay. We said beta-1 is heart, beta-2, lungs. So beta-2 is the bronchial, smooth muscle relaxation. Helps alleviate bronchospasms. Wheezes and dyspnea. How many of you guys in clinical have seen breathing treatments given? You'll see albuterol. Has Curly talked about those? Yeah. Okay. You'll see catecholamines, epinephrine, given an anaphylaxis. Somebody mentioned that word earlier. The anaphylaxis is a severe reaction to something you are allergic to. So when we talk about catecholamines, I want you to know that the catecholamine, epinephrine, so epinephrine does all those parasympathetic responses. Okay? Questions? I see some blank faces. What is the autonomic nervous system response? Two systems.
Sympathetic and parasympathetic.
Exactly. Sympathetic or parasympathetic. So what does the sympathetic system do? We're going to say fight or flight. And the parasympathetic does, they're two opposites. Okay. We said agonist was helper. So now let's look at the adrenergic system and how it affects alpha cells, receptors, beta cells, 1 and 2. So when we look at alpha receptors, we talked about clonidine, right? So blood vessels, eyes, bladder, and prostate. Those medications can affect here. Alpha-2, nerve endings in the sympathetic nervous system. Yes, ma'am.
So did you say the epinephrine was used in the sympathetic and then the norepinephrine, the parasympathetic?
Epinephrine and norepinephrine are two the opposites of each other. Adrenergic, sympathetic nervous system. You with me?
Yeah.
Okay. So beta cells, we said, affect the heart, right? And they also affect the kidneys. But your beta 2s, when you see these meds, smooth muscle and lung. Beta 2, 2 lungs. Beta 1, 1 heart. Ms. Curley talked about some alpha medications. Y'all remember these? Pseudoephedrine and phenylene? So here's what these meds do. It's just a repeat of what she talked to you about when she talked about these medications. Vasoconstrict. Okay. Alpha-2. Clonidine used for hypertension. Works on the central nervous system. Beta 1, we talked about. Works on the heart, right? Metoprolol. Another medication that you will see here is the butamine. Okay. Beta 2s can affect the lungs in dilating. So I can bring computer on. This slide right here, I would commit to, it will help me remember these medications, betas. Is there a majority of your antihypertensive medicines? All right, questions? What two catecholamines do I have? Epinephrine and NUR. What is epinephrine gonna do to my body? Fight or flight, vasoconstrict, right? Now, you have PowerPoints in your folder. There's one about hypertension. That is for you to know what hypertension is, okay? Just a review. Do you need a moment to clear your mind and then do cholesterol and triglycerides right now? I see it now. All right. Take another 5. The first part, 2 slides, Ms. Guyton, of that's not going to be in the recording. So this picture comes from your book as well. So you need to remember the bad cholesterol is LDL. And the good is HDL, okay? Just remember that. Picture is in your pharmacology book. What are triglycerides and how are they made? Do you know? They're part of the fat. Do we need a lot of triglyceride in our blood? Does it affect our heart? It can, coronary artery disease, okay? How do we get it? It's formed from fats, lipids you eat. What happens when you eat something your body doesn't need right now? It stores it, right? As lipids. It circulates around in the body. You ever heard the old saying, you are what you eat? It's where this triglyceride comes from. What are fat cells in the body called? Adipose. Is every heavy person with a lot of adipose, do they have trouble with this? No. Are there people who have high cholesterol and triglycerides that are heavy? Have trouble with this? Some, yeah. Are there skinny people that can have high triglyceride and cholesterol levels? Yeah, they can. Family history. Okay. High triglycerides put you at risk for hardening of the arteries. What do we call that? Say it louder. Arteriosclerosis. You'll see that word. So what does all this put you at risk for? Stroke, heart attack, obesity, and heart disease. Those are important to remember. The body needs some sort of fat because we have hormones that are fat dependent. So we travel around the body and we're taking care of them that way. How do we get fats in our diets? By things we eat. Give me some examples. What kind of meat? Red meats, right? Fatty meats, dairy products, milk, whole milk specifically. When y'all go to the grocery store and you pick up that salt substitute, read the fat amounts on some of your red meats. It's huge. Are we supposed to not eat all red meats? We can eat as long as we are mindful of what we're eating. So your vitamins that I was mentioning that need fat to help them dissolve, A, D, E, and K. Heard that before? So if your patient's taking vitamins A and D, they need to have some sort of fat in their system to help them absorb those vitamins. Okay. So essential fatty acids are good for our body. Omega-3, you heard that word? Yeah. So those are good fatty acids to eat. What is organ in our body that's made of a lot of fat? Brain. So when you have a client that comes in and they need to get some lab tests, and they're getting their triglyceride and cholesterol levels done, they need to be fasting or not fasting? Fasting, very important. So where do we want that cholesterol level to be? Less than 200. So what is the HDL? Healthy or not healthy? Healthy. LDL is the, I remember it, H, healthy, LDL, lethal. Okay. What are some non-pharmacological ways to reduce these levels in our body? Diet and exercise. Will it help lower our blood pressure? Sure will. Stop smoking. What does smoking do? It raises your LDL level. Is that the good one or the bad one? The bad one. How many patients have you taken care of that have coronary artery disease or heart disease? A lot. Okay. Too much fat. Here's your lifestyle changes. We said diet and exercise. 30 minutes a day. I'm guilty of not doing that. Avoid sugar and refined sugar. That makes our triglyceride levels go up. Where do we find refined carbohydrates?
White bread.
Sugar and white stuff. Turn little Debbie. They're really good.
Yes, they are.
All that cream in the center. And they taste good, right? We need to be at an ideal weight. Limit the amount of alcohol. And stop smoking. And stress, right? So there's a medication we can give that helps us lower lipids and triglycerides. What is it called? Antilipidemics. For statins, how many statins have you given? Several? Couple? Okay. So statins lower cholesterol. Fibrates are medications such as fenofibrate or gemfibrozil. Okay. Thank you. Those are medicines that help with triglycerides and cholesterol. So you heard of folks taking fish oils. Remember we talked about over-the-counters? So fish oils have a side effect. You remember what that side effect was if you took too much? Say it again. In the blood, they do. So do we want to take a large amount of these and a large amount of cumin? Well, those and omega-3s are medications that you will see that are used for as fish oils for helping decrease cholesterol. I'm not sure that they use this one, niacin. What's niacin? It's a vitamin, right? B what? 3. So there was studies done, American Heart put out, that certain amounts of niacin will help decrease these levels. Is everybody's body the same? No. Absolutely not. A lot of side effects with the niacin. All right, here comes pronunciation from. Most meds you've seen has two names, right? Lovastatin. Its other name is Mevacor. Simvastatin. Zocor. Atorvastatin. See a lot of that one. Lipitor. Pravastatin. What's the suffix? Statin. Rosuvastatin. Crestor. This one, just an FYI, stronger than straight HDL. I don't need to know that for testing purposes. Okay. So how does statins work? They work in the liver, right? We said that earlier. There's an enzyme your liver makes to process cholesterol. The statins work to inhibit this enzyme. Okay. HMG-CoA. The name of that enzyme is what helps your body make cholesterol. So if I have too much, I need something to help lower that. Where are statins going to work? Liver. Where that is made. The enzyme, sorry. When do statins work best? Evidence-based research shows they work best. Take it at night. What do I need to teach my client? Take it before you go to bed. The exception of that is Lipitor. Okay. How are they going to prescribe statins? Your physician or healthcare provider may start you on a certain dose, usually a higher dose, especially if you have coronary artery disease. You get those levels down pretty quickly. What do you think we need to teach that client when they start statins? Where is it made? Where does it work? Liver. So we need to teach them about their liver. What does your liver do? If you start having liver problems, we do need to let know. Healthcare provider. Statins reduce the total amount of cholesterol floating around in your blood. They help decrease those plaque formations in your arteries and prevent them from rupturing or being clogged. Statins are known to have an anti-inflammatory effect. And there's also research, just for your information, that statins stimulate neurogenesis and are used for folks with Alzheimer's. That's not a testing, but that's just nice to know, okay? What do statins cause? Side effects. The biggest one, myalgias. Yes, Ron.
So I know that we just talked about tissue integrity and we talked about niacin, but that is not the statin. Right.
I missed your question.
I mean, it go, but we just talked about tissue integrity and we talked about the niacin, like powder and things. And not completely different.
I thought that's what you said, but not that. Powder for antifungal, right?
Yeah.
Those not really,
Doesn't.
so just be mindful that all words that end in stat.
Right.
Okay? Did y'all hear that? Biggest complaint of patients, muscle aches and pains. Do y'all know what rhabdomyolysis is?
Yeah.
It was on the ticket. It was like.
Rhabdomyolysis happens when the muscle cells break down and they prevent the kidneys from function because the kidneys can't get rid of proteins. The rhabdomyolysis shuts your muscles down. Okay. 1 out of 20 clients experience muscle pain. Do you think it's something you want to report to the healthcare provider?
No.
You do. Yeah. Because the muscle pains and myalgias, one of the big complaints. The dose may need to be stopped. The dose may need to be changed, or the medication may be changed. There's a handful of statins out there. So find what works for you. What do we need to assess? If you're giving a statin, I need to look at my liver enzymes, right? Make sure my liver's good before I take it. What's this CPK? CPK is a lab that detects muscle damage. Okay? You won't see it ordered on everybody. Here's this grapefruit juice again. Grapefruits and grapefruit juice. What do you think happens when you eat grapefruits or drink grapefruit juice and you take that? It decreases absorption of the statin. Can I drink my grapefruit juice? Later, 8 hours difference. Morning and night. Okay. Why do we not want to stop this medication abruptly? It can cause an increase in my triglyceride and cholesterol. Do I need that? Not if I'm taking it for that reason. So we want to use caution, as I said, with your AST and ALT and your liver patients, so your hepatic disease patients. Don't take if you're pregnant or breastfeeding. Another one. Okay. How's it going to lower my triglycerides? I'll have to do some other things. Yes, ma'am.
So once you're on this medication, you always have to be on this medication?
Not always. But you have to consider heart disease and medication. Do I have to take this medication for the rest of my life? Some people do, some don't. If I adjust the things in my life to help me get rid of all of that, then hopefully not, probably not. Healthcare provider decision. That's a good question. Yes, ma'am.
I have two questions. The first one is whenever you know about NUR grapefruit and how it decreases absorption, did you say take 8 hours later?
If you're drinking grapefruit juice, you need that 8 hour interval between. So that's why it's best to take that statin late at night or before you go to bed. So
Okay.
drink grapefruit juice in the morning.
Another question was whenever it said don't stop med abruptly, does that always happen whenever you're given a high dose at first? And if you stop it abruptly, it causes the harmful.
Anytime that you stop a medication abruptly, let's talk about our antihypertensives. We stop that abruptly, what's going to happen? It's a rebound effect. I'm going to get hypertensive. If I stop my statin abruptly, no matter what dose, what can happen?
Rebound.
It's a rebound effect.
You're immediately stopping at source. So.
Yes.
Okay.
Makes sense?
Mhm.
Okay, good question. So we talked about fish oils. We talked about Levosa. Let's talk about it. It's one of the newer medications, not so much new, but what they're using in combination with a statin to help get those levels down quicker. High triglycerides increase your risk for what? Heart disease. What else?
Neuropathy.
Because your brain's made of 60% fat, fatty liver, and pancreatitis. I've seen some folks with this.
Yeah.
So Zetia, another type of statin, works in the GI tract. Where's all that bile go? Through your GI system, right? So these folks can take Zetia to help work with their bile and getting rid of cholesterol. Okay. Combination drug, you may see ezetimibe, simvastatin, name of the drug is Victoria. All medications to help reduce. Remember, this is a review. Grapefruit juice, take apart from your statin. How long? At least 8 hours. It helps. It doesn't help you absorb your statin so you can get rid of your triglyceride and cholesterol. It breaks. It keeps it from working. Inhibits your liver enzymes. Okay. interactions. If you drink grapefruit juice and you take if you drink it, that grapefruit juice can last in your system up to 72 hours. Why do we drink grapefruit juice? We either like it or the source of vitamin C. So just know that that 72 hours still be in your system. So if it bothers my statin and my levels aren't lowering, maybe I need to give up my grapefruit juice. Make sense? Okay. Other news about statins, simvastatin, seen that one. Grapefruit juice with simvastatin blocks the absorption 300% more than if you were taking atorvastatin. So it blocks it more. So the two differences of the drugs and how grapefruit juice affects them. Who do you think has the most highest incidence of problems? Florida. They grow these grapefruits and oranges, right? So here is you a video on how statins work. You remember I said you may not hear what I say, or you may not make sense when I say it. So having an alternative language helps.
I took the lead, I'm sorry.
Okay. Helps understand it. So that is the end of antilipidemics. Now let me ask you a question. Are statins made for everybody? No. So you'll find this PowerPoint in your folder, RAAS. It is a review of what the system does for your knowledge, okay? You will also find, as I said, the hypertension one for your knowledge to help you understand what hypertension is, why we treat it, why it needs to be treated, where your blood pressure needs to be. And we all know our bodies are not made the same. Do you have questions about any of the antihypertensive medications we discussed, or antilipidemics, iron? What other meds have we talked about? Nitrates, linoxin, digoxin? No? Shauna?
So as far as like, I know we're gonna, we have a review next week as well, but so that would be for our knowledge so that we know how those drugs work. Like the hypertension information.
So you need to know, sorry.
Yeah, so there's, so she just said that there's the hypertension, and then there's that, and you have to understand how that works to be able to utilize medication, but it's not something that is going to like a specific question of it. Oh, okay.
Your question is?
The nitrates.
It's the job.
Oh, digoxin, okay.
Nitrates is nitroglycerin.
Okay.
Thank you.
Any other questions?
Yeah.
That is a correct thing. So we are here till 12. I'm gonna give you another 5-10 minutes. If you need something to eat, something to drink, something to go potty, clear your mind. I would like you to come back. I'm going to quiz you and give you questions about what we just went over. See how much you understand. Help you apply what we've done to questions. So I would like to see computers closed, and let's test your brain. Are they still testing? Okay.
No, yeah.